100%, 120%, is we are all so fortunate to live in the time of human being history that we're in. Sit there and think about all the phenomenal things that are going on in our world around us. I'm talking about positive things. I mean, amazing. And if you sit there and think about your foray into the health career field, think about all the phenomenal tools that have been developed to help promote healthcare. It's spectacular. You know, when I was your age, x-rays for the most part were about it. There was CT, MRI imaging was very far down the road. Sit there and think about MRI, magnetic resonancy. You're coming along and you're getting protons to basically vibrate, and you're mapping that. That's space age type technology. So as you're out there going through the field, be appreciative of the fact that there's just such an abundance of information. Yeah, it's kind of a heavy load, but you're gaining access to healthcare that is spectacular compared to what any generation that preceded you experienced. The challenge is to be able to afford it. That's a big challenge. All right, so contrasting skeletal, cardiac, and smooth muscle. All right, so we're going to create a table. Love my tables. Before I do this, though, I should talk about, let's just talk about muscle. This is something that you should have learned in your anatomy class. Then we can think about muscle being categorized as either striated or non-striated. Striations, it's the banding patterns that you see when you use a microscope to look at the histology of skeletal or cardiac muscle. You'll see banding, and that banding is simply a representation of the overlap between the thick and the thin filaments, the presence of Z-lines. That's what we're talking about. I'm just going to put the word banding. I'll just leave that over here. So what this really means is the presence of striations. I can express striations. The presence of sarcomeres. And understriated, we've got skeletal muscle and cardiac muscle. And when we talk about non-striated here, we're talking about smooth muscle. All right, coming back to the table, we're going to put muscle property in the far left-hand column. The next column, we're going to have skeletal muscle. Cardiac muscle. And smooth muscle. All right, first property. This one's an easy one. Sarcomeres present. And all of you would tell me that for skeletal muscle, yes. Cardiac muscle, yes. Smooth muscle, no. Next category, we're going to talk about excitation, contraction, coupling. So I'm just going to put E, C, coupling. For skeletal muscle, I'm going to put troponin C. For cardiac muscle, troponin C. For a smooth muscle, I'm going to put MLCK. Next category. Development of the sarcoplasmic reticulum. So let me just explain what I mean by that. Is there an extensive amount of sarcoplasmic reticulum? Is there a moderate amount of sarcoplasmic reticulum? Or is there very little sarcoplasmic reticulum? For skeletal muscle, it's extensive. Different interpretation of that word. Here's what it means, what it really means. Is that the sarcoplasmic reticulum floods the muscle with calcium so that you saturate all the binding sites at troponin C. So I'll just say it again, is that the sarcoplasmic reticulum is so highly developed in skeletal muscle that it releases an overabundance of calcium that saturates all the calcium binding sites on troponin C. Cardiac muscle. The development of the sarcoplasmic reticulum is moderate. And what that means is that extracellular sources of calcium can affect the contractility of cardiac muscle. Say it one more time. Is that when we talk about moderate development, that means that extracellular sources of calcium can play an important role in regulating the contractility of muscle. And just to give you a heads up, I can test you on that for this test, but certainly in test number 4, sympathetic neurons act on beta-1 adrenergic receptors in the heart. There's an abundance of beta-1 adrenergic receptors in the heart. Those receptors, as you'll find out, play a key role in regulating calcium levels in cardiac muscle. And then smooth muscle, very little. All right, and then the last one I'm going to put up here, there's many that I can put up, but the last one we're going to go with is the innervation. Innervation. Miss Camilla, what can you tell us about the innervation of skeletal muscle? You can. Yes, you can. Let's see here. Sarah Wu. Sarah, what are you going to tell us? about the innervation. It's not the past type of innervation, that's a different type of innervation.
Expensive.
Sure you can, of course you can. Yep. Let's see here, Andrew. Andrew, what would you tell us about the innervation of skeletal muscle?
I'm not too sure.
Do you have your hand?
No, but I would say hi.
Hi, okay, all right.
What specifically do you mean?
I'm not sure.
Nerves.
Tyler said, what do I specifically mean? What type of nerves or neurons is controlling skeletal muscle? Mr. Lewis, what's that? Yeah, alpha motor neurons, right? So here I'm going to put, alpha motor neurons. Can anybody tell me anything about the properties of these alpha motor neurons? Are they skinny little buggers? Do they have any?
Large and myelinated.
They're highly myelinated, and the radius is very large. That's right. Good. Okay. Cardiac muscle. What's the innervation of the cardiac muscle? Mr. Cal, you said you had anatomy last semester,
Yes.
and you read it out. Your friends like Jocelyn. I'm joking. I'm having fun here. Jocelyn, you had anatomy with him, and he told me that you were the star student in that class. That's what he told me. What would you say is the innervation of cardiac muscle? Good, that's exactly right. So you sit there and say that it's receiving input from the autonomic nervous system. Specifically, we're talking about sympathetic and parasympathetic neurons. Good job. Excellent day. Okay, so here we're going to say, I'm just going to put A and S. And you're going to understand that we're talking about sympathetic and parasympathetic input. And then how about for smooth muscle? There was a funny diagram that I kept talking about all the time. And Mr. Cal, it's funny that you said that Jocelyn was a superstar of the class because I was talking to her and she told me that you were the superstar of that class. So you're up to bat.
Also innervated by the autonomic nervous systems.
Very good. Good. The autonomic nervous system, that's exactly right. Very good. All right, so that's a simple little chart. Like I said, we can make it much more complex, but there's no need to do that. Questions before I move on? Don't be bashful. Everybody's going to be bashful? All right, so we're transitioning back, we're transitioning back to our story on the 5-step model, especially as it applies to respiratory physiology. I talked to you last week about the concept of dead space, and remember that when we talk about dead space, we're talking about a volume of the lung where there is no gas exchange. That's the simple definition of dead space. A region in the lung where there is no gas exchange. I'm going to actually create a little homework assignment for you guys to do some calculations, just so that you kind of are going through the process and sitting there and getting nicely acquainted with how to do these calculations. They're simple calculations, but for experimental ventilation, for the alveolar ventilation rate, yada, yada, yada. Simple stuff, but stuff that you should be able to do. Test night, it's logic, really. If you sit there and think about it, it's just logic 101. It's a process of learning the logic. That's what it's really all about. You learned about forced vital capacity. You've learned about forced expired volume at 1 second. You've learned about Ohm's law. And so now what I'm going to do is I'm going to continue talking about these pulmonary function tests, and we're going to talk a little bit more about what is known as obstructive lung disease. I'm going to talk about restrictive lung disease. We're going to pass on Poiseuille's law for right now. Talk about a couple types of lung disease: emphysema, bronchitis, chronic obstructive pulmonary disease, COPD, a terrible disease to have. And if you see folks sometimes with little snares in their nostrils and it's connected to an oxygen tank or an oxygen generator, probably a number of those folks are suffering from COPD, chronic obstructive pulmonary disease. And I was watching a commercial last night, I think it was, and they're showing a little scent machine, diffuser, inside a car. And I'm sitting there and they're showing this thing just creating this puff of gas that kind of goes off in the car. And from my perspective, we don't want to be breathing in anything where we don't know the chemical composition of what we're breathing into our lungs. It's just not smart to do that. And so you sit there and think about vaping and all the issues associated with vaping, cigarettes, smoking, terrible thing to deal with. So smoking is one of the key culprits for the development of chronic obstructive pulmonary disease. A terrible thing, because basically it causes the lung to begin to break down. And we're not even talking about the occurrence of lung cancer, which, yikes, hopefully I never have to deal with anything like that. I've already talked to you about the use of inhalers and albuterol, so that part of the story you should have down. So that's what we're going to do. That will then basically take care of a large part of step number 1 and step number 2 in our 5-step model. So here's a graph. On the y-axis, we've got volume. This is in liters. And we're going to simply go in increments of 1 liter. We've got time on the x-axis, going in increments of 1 second. Commercial break, time for a commercial. So I have suggested to you that you keep a separate piece of paper for a drug list. The other thing I would recommend to you is you keep a separate paper for all the abbreviations that are used to describe the various types of measurements. For instance, tidal volume. Capital V, lowerscript t. If you write TV, I'm not going to count that as correct. I'm giving you the correct terms that are used in respiratory physiology way. Lots of terms coming at you that you need to know. So I think just as a good study aid, if you have a separate page that's got all these terms on it, that will help you out hopefully a lot, rather than have them all scattered all over the place. And you sit there and go, what does PaO2 stand for? Is he talking about the partial pressure of alveolar O2 or the partial pressure of arterial O2? And both of them have the notation of PaO2. But there are rules. So I'll explain those rules to you as I get there. Okay, so we've got time on our x-axis, and this is in seconds. We're doing a pulmonary function test. Here's our data we get. In this instance, all of you would tell me that the tidal volume is 4 liters, except the right term here would not be VT, but it would be the forced, what? Forced vital capacity. Very good. So here I'm going to write FVC, the forced vital capacity. As I mentioned to you previously, to get a sense of the rate at which air is flowing out of the lungs, we simply we start at 1 second on the x-axis, draw a perpendicular line to where it intersects our curve, and then we draw a perpendicular line to where it intercepts the y-axis. In this case, this would represent our forced expired volume at 1 second, FEV1. Make sure that you understand that FEV1 is expressed as a percentage of forced vital capacity. In the formula, so we talk about normalized FEV1, is equal to FEV divided by forced vital capacity times 100. Andrew, what's the normal range for FEV1? Say that again?
3/4.
Well, that certainly fits in the range, but the question I'm asking is what is the range for normal FEV1? Elizabeth, good evening. How are you doing?
I think is it between 65 and 85%?
Thumbs up. Very good. Excellent. So our normal range is 65 to 85% of forced vital capacity. I gave you this scenario where we have an individual, and the specific example I gave you is a little child, Susie, but it can happen to anybody. And so we'll say that we've got this adult individual who suffers from asthma, and we see a curve that looks something like this. And in this instance, we find out that the FEV1 is about 3/8. That would be about 36%. So 36%, that certainly doesn't fall within the normal range. And we can categorize lung disease as being either obstructive or restrictive. So we're going to say that there are two broad categories of lung disease, one of which is known as obstructive. And this actually is a good term, I think, because coming back to the simple little diagram that I've been providing for you, we can have a situation where our smooth muscle cells become irritated, they contract, they narrow the airway, and in so doing, this obstructs the flow of air through the airway. A good term, I think, to describe what's going on. And so, as I've already described for you, the different types of conditions that can lead to this are things like asthma, and COPD. Look at the term. By the way, asthma, acute, typically, acute. But look at this term, chronic, meaning it's always there. And that O stands for what? Obstructive. So in individuals who have COPD, they have an inflammation of the bronchi. And so this inflammation irritates the smooth muscle cells, causing them to contract. So in COPD, there's bronchitis, and there's a phenomena where the alveoli, the walls that separate one alveoli from the other, are broken down. So imagine that, sorry. So imagine that we've got alveoli. We'll make it very simple. We've got 3 alveoli. And now assume that we break down the walls between these individual alveoli. Mr. Tyler, you either are smiling because you think my...
There's no good news in it, Mary.
What's happening in this situation? If you can answer without laughing.
If the walls of the alveoli are fusing together, doesn't that mean there's less surface area for oxygen?
Fantastic, that's exactly right. So that's exactly right. The diffusive surface area has been decreased. And when we talk about diffusive surface area, you're thinking about Fick's law of diffusion. Very good. Excellent. Here I'm going to put loss of diffusive surface area. Okay, that's some simple background with regards to obstructive lung disease. The other type of lung disease is referred to as restrictive lung disease. That also is a good term, I think. Here's what that term means. Is that imagine that we'll say that what I'm showing up here is the alveoli, the geometry of the alveoli in the deflated state. Now you come along and you breathe air in. And the alveoli, of course this is a gross exaggeration, inflates. So that would be what we call our normal hypothetical. But what if we had an individual where there was a buildup of connective tissue in the walls of the alveoli? So here what I'm going to do is I'm going to just put a little squiggly dark line around the walls of the alveoli. And I'm going to put increased connective tissue. Let's see here. Oh, Mr. Lamb's not here tonight. Mandy. What's going to happen to forced vital capacity? Got to speak up loud. It's going to increase, that's exactly right. Is that what you said? Huh?
Yes.
Don't let me put words in your mouth.
Okay, it'll decrease.
Restrictive. What is going to happen to the ability to inflate the alveoli? It's restricted, and therefore, in this individual, their vital capacity will be decreased, right? That's what you said to begin with, correct? So, now this individual goes to breathe air in, and because we've got this proliferation of connective tissue, we're not able to inflate our alveoli as much. So this individual comes along and they perform a pulmonary function test. They go see their general practitioner, their PA, and they sit there and say, you know, lately I feel like I'm really struggling to breathe. That would be a pretty uncommon remark, don't you think? How many of you in here have struggled with breathing? Hopefully none of you. I mean, breathe. You struggle for breathing? Well,
I had bronchitis.
okay, all right. Yeah. So, but that's something that can be remediated, and hopefully it's something that doesn't last for months and months and months and months. But that's a very unusual thing to be talking about. So you got this individual who comes in and says, I feel very short of breath. So you decide you're going to order a pulmonary function test, and here's what you see. Anybody? In this instance, what's the forced vital capacity? The red represents this individual in their normal state. You're going to now say that their forced vital capacity is still 4 liters, right? 3.5 liters, 3 liters, 2.5 liters, 2 liters. Yeah, it's 2 liters now. What's happened to the forced expired volume in 1 second? Is that 65 to 85% of their forced vital capacity? Is it 40% of their forced vital capacity, or is it something different? Anybody? It almost looks like it's 100%. It does, right? It's very high. As a matter of fact, it exceeds that 85%. Now, I'll say that in respiratory physiology land, 65 to 85% is kind of a general rule. But here we've got something very extreme. We've got a remarkably reduced forced vital capacity, and we have this very high forced expired volume at 1 second. So what's going on is we've got in this individual, we've got this proliferation of connective tissue that restricts the ability to inflate the alveoli. And we've got this proliferation of connective tissue. And that connective tissue has got these elastic properties. Elastic properties. Anybody have a ruler in here? Do we have anybody's got a ruler? Nobody's got a ruler. I have to start bringing my own ruler in. Ah, perfect. Huh? Tiny. Sorry. Well, sadly, this is a metal one, and I'm not going to attempt to bend it. But hopefully you'll get the idea. If I come along and I create a force field pushing in that direction, this ruler is going to bend in that direction. Yeah? No? Maybe so? And if I remove that force field, then this ruler would come back to its steady state condition or its resting state, which would be here. So if I increase the amount of springs, if I increase the elasticity, is this going to spring back faster or slower? It's going to spring back faster. And that's exactly what's happening here, is we've increased the connective tissue, and so when we inflate the alveoli, that puts a lot of tension in the connective tissue, which causes the alveoli to collapse much faster than normal, causing the FEV1 to be much higher than we would expect under normal conditions. There's a terrible disease known as scleroderma. Anybody in here know of scleroderma? Scleroderma is this defect in the gene expression for collagen. And so it causes collagen to proliferate abnormally. And so you can have proliferation of collagen in the walls of the alveoli, creating this disorder. Huge problem, because this is progressive. As the disease progresses, the amount of collagen increases. And so over the course of time, the ability to inflate the alveoli is progressively lost. And that's going to cause the alveolar ventilation rate to do what? It's going to go down, right? And now you're in big trouble. And as it turns out, one of my mentors up at UCLA, his wife developed scleroderma. And scleroderma not only can affect the lungs, but it can affect the heart. And so the heart's a pump. It's got to be able to fill up with blood. So if your heart can't fill up with blood, you cannot pump out adequate amounts of oxygen. So imagine if you have an individual who's got this disorder that's acting primarily in the lungs, what's in the horizon for that individual? How about the lungs? What are you going to do to save this person? There's no genetic tools available to come along and to reverse this effect. There's really only one thing you can do. What is it? A lung transplant. That's exactly right. Yeah. This individual I'm seeing, after about 30 years of suffering from scleroderma, had a lung transplant back about 10 years ago. Actually doing quite well. So we have problems with the lungs, we've got problems with the heart. In these individuals, the proliferation of connective tissue in the face, so that the skin gets drawn back, kind of, they got like this effect where it looks like it's being stretched. Imagine your hands, your ability to flex your hands. We take all these things for granted, and you have this proliferation of the skin in your hands, and now all of a sudden that skin becomes very tight, and now all of a sudden the ability to move your fingers normally is dramatically changed. So make sure you know about restrictive lung disease. We're talking about a proliferation of connective tissue in the walls of the alveoli that prevents the alveoli from properly inflating during a normal breathing cycle. Okay, now sadly, time has run out. That's it for tonight.